1, 2,
and female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's
300 please.
I'll keep your card again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is also dropping.
45 minutes of CPR and no return of circulation. Okay.
Alright guys, so this right here is going to be over dysrhythmia, arrhythmias. I don't know the difference between a dysrhythmia or an arrhythmia. If there is a difference, please, let me know. Or, for me, it doesn't really matter. I use the terms interchangeably. But what I will say is I do not know what arrhythmias they're going to go over in this particular episode because I haven't listened to it yet. But we can just kind of do like a little overview real quick. So your easy ones are going to be VFib, just look like a bunch of squiggles on the EKG paper or on the lead strip. And then you have fine VFib. Fine VFib, if you're taking like an AHA course, it will literally look like asystole, but they'll have a little bit of like a little wave in there, and they're going to be like, oh, that's coarse, or that's fine VFib. And you're like, that's asystole, but they're going to call it, fine VFib. And for the AHA is concerned, asystole is just quite literally a flat line. But in an emergency situation, fine VFib and asystole are going to look the same. But you have VFib, which is, like I said, it's going to be just that squiggle line on the EKG paper. And then you have fine VFib. It's just going to be smaller squiggles on the EKG paper. And then you have your VTAC, which is just going to look like big tombstones or the McDonald's sign over and over again. And then you have torsades, which you will get, the really, really big VTAC. And then it shrinks down into small VTAC or VFib. And then it shoots back out to VTAC again, and then VFib, and then VTAC. At least that's the way it looks on the EKG paper. Again, I'm not a cardiologist by any means, so I don't know what the hell is actually happening in torsades. All I know is that you're going to try to slow that shit down with some MAG and then hope for the best with your other ACLS drugs. And then you will have your AFib with RVR. Now, the big thing with AFib with RVR is that you're going to have AFib, and then in a run of RVR, you're going to have a very rapid, QRS complex, that are really, really close together. And then you'll get your rhythm back, of your AFib, which is that irregular, regular, kind of pattern. And then your RVR again will be like a really short, squished together QRS complex next to each other, maybe 3, 4, 5 of them. And then it shoots back out to your normal rhythm. And then you have a flutter. Now, not too long ago in the ER, I heard the term a flutter with RVR. I don't know if that's a thing. But if it is, then you're going to be looking for the same thing. You're going to be looking for your sawtooth pattern in between your QRS complexes. And then I'm assuming your QRS complexes are going to squish together. And you're going to get like 4, 5, 6 beats. And then it'll shoot back out to your normal rhythm. And then shoot back down into those really tight QRS complexes. And then I guess shoot back out to like the regular, irregular rhythm. And then that's your A flutter. And you have your NSR, which is your normal sinus. And then you have Brady, and then you have your tachy. And then I don't know if they're going to get into heart blocks in this particular episode. But the easiest way to tell a heart block is your heart blocks are going to be predicated by your P wave. And everything with heart blocks is going to be P wave related. So your first degree heart block, you're going to be having your P wave, which is going to be a little bit further away from your QRS complex than you would like it to be. I can't remember the exact numbers because I don't have an EKG ruler in front of me or the criteria, but your P wave will be completely, kind of moved back a little bit. And that right there would be your first degree. Your second degree type 1, if I'm not mistaken, is your Mobitz 1. If I'm not mistaken, I should probably look this up before I give you guys the wrong information. Let me pause real quick. Okay, just checked it. So Mobitz 1 is your Winkenbach, arrhythmia, right? Heart block. And so it is the arrhythmia that has that little rhyme to it. Wider drop. Then you have a Winkenbach. Again, you're looking at your P wave. All these heart blocks, my little piece of advice to you guys, don't overcomplicate this shit. It's literally your P wave for these heart blocks. So with type 1 or with your first degree heart block, your P wave is sitting a little bit further back from the QRS complex, right? In your Mobitz 1, your second degree heart block type 1 is your P wave will be normal, and then it'll get further away from the QRS complex and then further away from the complex again. And then you'll have a drop beat, and then your P wave will show back up right next to your QRS complex and then start getting wider and wider out from the QRS complex before another beat drops. Okay, that's your type 1 for Mobitz. And then your type 2 is your P wave will stay the same. Whether it's further or closer to your QRS complex is irrelevant, but it'll be stationary. And then on your EKG paper, you'll just have a drop beat just out of nowhere, right? And then you'll get your beat back, and then the P wave will be right where it needs to be, okay? And then your third degree heart block is going to be your P wave is doing its own damn thing, right? So the atria are just doing their own thing. They're not synchronized with their ventricles at all. So they're contracting without any coordination with the ventricles, right? And so your P wave will be where it's supposed to be. It'll be like in this random ass spot between your T wave and your QRS complex, or hell, it could be hidden in the T wave. And what it will look like is that you'll have this little notch up or this little spike in your T wave, and then you'll have your QRS complex, or hell, your P wave could be hidden in the QRS complex, which is very difficult to kind of see on the EKG paper. You might get lucky and see a notch, in your, your R wave. You might get a little higher of a notch than everywhere else, or it might look like a bundle branch block. So you might get like a little cat ear looking thing, or maybe even a W in your, QRS, I guess your Q wave, whichever one is the bottom one that comes down. Damn it, it comes down, right? You might get a W with that, right? And so you might get fortunate enough to get that, right? But typically your P wave is going to be doing its own fucking thing, right? And it's not going to follow any sort of logic. It's just going to be doing its own thing, And so that's how you know that you're in a third degree heart block, which is your more serious heart block. I will say the rarest ones that I've seen is a type 1, your Winkenbach, right? Where it just gets wider and wider and then drops, right? I've only seen it once in clinical practice. And me and the hospitalist were like, what? Is that a type 1? And we were all excited. And the patient had no idea what the hell we were talking about because it's so uncommon to find. But so with your heart blocks, don't overcomplicate the shit. It is all going to be determined on your P wave. Okay? Again, your P wave is going to determine what type of heart block you have. All right? So don't be looking at your QRS complex. Don't be looking at your fucking T wave. Everything about heart blocks is going to be in your P wave, as in papa, your P wave. Okay? And then, again, I don't know if they're going to be getting into these, but you have your bundle branch blocks. So, again, I don't know, like lead 1, 2, 3, your V1, V2, V3, in your AVR, and I think it's SVR. Like, I don't know where you're going to find these at. Like, I know that, nurse practitioners and stuff like that, they can look, and your PAs and your MDs will look at the strip and they'll like compare lead 1 and 2 to like AVR or something like that. But for our intensive purposes for RN school, is your left and right bundle branch blocks. If I'm not mistaken, I believe, let me check before I give you guys wrong information. So with your left bundle branch block, your EKG paper might show like a little Batman looking thing where your QRS complex looks like either a cat or a Batman, where there's like 2 peaks, at the top of the QRS complex. It'll have like 2 peaks. Or your QRS complex on the part that goes down will look like a W. Okay. And then on your right bundle branch block, like when you're getting ready to repolarize, go for the ventricles to repolarize to get your T wave, that little space at the end of the QRS complex before you get to the T wave will look like a U. Like it'll dip down and make like a U, or you might even get an inverted T wave, right? And then they might go over, potassium, your peak T waves. Just remember, as the more and more potassium the body has, it'll start really throwing off the heart's ability to regulate itself. And so you can get these massive peak T waves to the point to where the QRS complex completely fades away as the potassium gets higher, to where the potassium gets so high that the only thing you're going to look at is a T wave. And at that point, you're just going to be running into VTAC if they sneeze, right? So it doesn't take much for them to get thrown into VTAC if they have that much potassium. So you're going to be looking at like insulin with dextrose, your DI, and then you're going to be looking at calcium, especially in high potassium. You're going to be giving calcium gluconate. The way I describe it to my patients who have high potassium is that calcium is going to go in and kind of hug the heart, because the heart's kind of having like this anxiety attack right now. And so calcium will go in and kind of give the heart a hug and keep it stable and keep it from throwing itself into this wonky ass arrhythmia, right? So it goes in and it hugs the heart, and then you have K-exolate, right? So you can shit it out. And then a new one is going to be albuterol. So there we give a lot of albuterol, which also helps the shift. So it's called a shifting protocol. In the ER, we call it a shifting protocol. So you're looking at D50. You might give an amp or two at D50 and then start an insulin drip to get the potassium back into the cells. And then you're going to be giving calcium gluconate. You're going to be giving K-exolate or Lokelma, whichever one that you have on hand. And then if they're really, really bad off, they might get hemodialysis, emergent dialysis to pull that extra potassium out. And then you have your arrhythmias with calcium and stuff like that, okay? But the big ones are going to be like potassium. And we went over VTAC, VFib. We went over the bundle branch blocks. And then we went over your heart blocks. And then we went over your atrial dysrhythmias with A-flutter and AFib, and then your AFib with RVR and AFib, or A-flutter with RVR, which is something new to me. So outside of that, man, I think that's it. All right. This is going to be the episode over dysrhythmias. I just wanted to make sure that we covered those because I don't know what they're going to touch on in this episode, but I want to make sure that, especially for the heart blocks, that you guys don't get tripped up with the heart blocks. Again, broken record. You're looking at your fucking P wave, all right? Your P wave will determine what type of heart block you are in. If your P wave is sitting a little bit further from the QRS complex, you're in a heart block type. You're in a heart block 1, first degree heart block. And then if your P wave starts marching away from your QRS complex, and then you get a drop beat, that's going to be a Winky block. Or Mobitz type 1, second degree heart block, Mobitz type 1. And then if your P wave is stationary, and then you get a random drop beat, that's going to be a second degree heart block, Mobitz type 2. And then if your P wave is just all over the damn place, your atria are just contracting whenever the fuck they feel like it, then you're going to be in a third degree heart block. Okay, so again, your heart blocks are going to be determined by the P wave. This is coming from nursing school. This is not a cardiologist telling you this, but for your intensive testing purposes, okay, your heart blocks are going to be determined by your P wave. Now, if you want to be a cardiologist and you want to say, well, your V1 and your V2 and your AVR, leads need to look like this and all that, well, then you do that, man. But in the ER and for nursing on our end, when just looking at the shit, your P wave determines what type of heart block you have. All right. And then, yeah, that's it. All right, guys. Enjoy the episode. Okay, I'm back like a bad habit. I want to go over PVCs and then bigeminy and trigeminy. Again, I do not know what arrhythmias this episode will go over because I haven't listened to it yet. But your PVCs are your preventricular contractions. So you will have like a normal QRS complex, right? And then just out of nowhere, you'll get this really bizarre looking kind of beat looking thing. And it's just where the ventricles just kind of contracted a little too early. So what I've come to learn is the ventricles are extremely sensitive. And so if the ventricles start reading that they're not getting enough oxygen, then they'll start to freak out. And then they'll start throwing PVCs like all over the damn place, right? So for a good chunk, I'm not going to give a percentage, but I will say if your patient doesn't have a cardiac history and you're in the ER, wherever the hell you're at, if they don't have a cardiac history, then if you see PVCs, they're probably just sitting in a weird position and you might want to just sit them up, pull them up, put some oxygen on them, something to get them to get oxygenated, even though their pulse ox is probably reading 90 or something like that. Just slap some O2 on them at 2 liters and then see if that kind of resolves their weird looking PVCs. Because again, the ventricles are extremely sensitive. We had a patient that had a shunt that the terminating portion of it dipped a little too low into the heart, and then I guess it started, rubbing the ventricles as it was contracting, and so it would throw a little weird PVCs whenever she would sit in like a weird position. And she said it was normal and she can feel it, so she sits in certain positions that way it doesn't do that. But we'll go into bigeminy, and let me check before I give you guys wrong information. Okay, so bigeminy will be a normal QRS complex, and then you'll have a PVC, and then it'll be 1 for 1. So you'll have a QRS, and then you have a PVC, then you have a QRS, and then you have a PVC, you have a QRS, and then you have a PVC. That right there is going to be bigeminy. Okay. And then you have trigeminy, which is a 2-for-1 special. So you'll get 2 QRS complexes and then you'll get 1 PVC. So QRS, QRS, PVC, QRS, QRS, PVC, QRS, QRS, PVC. That will be trigeminy. Okay. So you'll just have your normal PVCs, and then you will have your bigeminy, which will be 1-for-1. So QRS, PVC, and then you'll have your trigeminy, which will be QRS, QRS, PVC. So a 2-for-1 special with trigeminy. So basically every second beat will be bigeminy, and then every third beat will be trigeminy. Okay. And now I think I am done.
You know, usually when we talk about a medical diagnosis, there's this expectation of absolute precision, almost like structural engineering, I guess.
Right, exactly. Like the structure has failed.
Yeah, like you break your femur, the x-ray shows a jagged white line right through the bone, and the orthopedic surgeon just points at the screen and says, well, there it is, broken.
It's incredibly binary. You know, it's clean, it's visible, and the intervention is just purely mechanical.
But then you step into the intensive care unit, you look at a failing heart, and suddenly that structural mechanical mindset, like relying on an x-ray machine, it feels completely inadequate.
Oh, it really does.
Because we usually think of the cardiovascular system as plumbing, right?
Yeah.
You have clogged pipes, blocked coronary arteries, physical fluid overload.
Right, the plumbing.
But the reality of the ICU is that the heart is actually a house with a really complex, highly sensitive electrical grid. And when that grid shorts out, the plumbing doesn't matter at all. The pump just stops.
It is the absolute definition of a critical failure. I mean, if the electricity fails, the pump dies, period.
Wow.
And to save a life in that exact moment, you have to completely shift your paradigm. You have to stop thinking like a plumber and, start thinking like a master electrician. You have to read the invisible currents traveling through the myocardium.
Which is wild to think about. So welcome to this deep dive. The mission today is clear, and honestly, it's intense.
Still very intense.
We are taking the source material provided, which is this massive stack of critical care literature, and we are going to try and transform you, the listener, into an elite ICU intensivist and critical care nursing instructor.
That's the goal.
We're looking exclusively at the electrical grid of the heart, the electrocardiographic monitoring, the cellular pathophysiology, and, well, the lethal dysrhythmias that occur when this whole system breaks down.
And just to be clear, assuming you already know the basics, we aren't going to waste time defining what a P-wave or a QRS complex is. We are diving straight into the deep end today.
Straight into it. I want to establish our methodology up front, too. We're doing this by aggressively applying the Pareto principle.
Yes, the 80-20 rule.
Exactly. We are stripping away the academic fluff and focusing on the exact, precise information that dictates your clinical understanding, your exam performance, and most importantly, bedside decision-making when a patient is actively dying in front of you.
And we are not just memorizing squiggles on a monitor today. We are using what sources call intensivist thinking.
Which I love. Tell us about that.
It's this vital cognitive framework. You don't just look at an ECG and shout out the name of a rhythm. That's what a novice does.
Right.
An intensivist approaches every single rhythm as a cascading sequence. So you ask, what is the underlying problem? How does that lead to failing physiology at a cellular and hemodynamic level?
Okay, problem, physiology.
Then what is the immediate threat to the patient's life? What is the specific intervention required? And finally, how do we reassess to prove our intervention actually worked?
Problem, failing physiology, immediate threat, intervention, reassessment. I love how systematic that is. So let's ground this in our house analogy.
Okay.
You have the plumbing, which is the physical blood flow, and the electricity, which is the conduction system. Today, we are the electricians.
I like that.
We are tracking the spark from the SA node, which is basically the main breaker panel of the house, down to the AV node, which acts as a relay box, and then down the bundle of His and Purkinje fibers, which is the actual wiring buried in the walls of the ventricles.
That is a perfect visualization. And before we get into the systemic failures, let's briefly establish the absolute essential rule of this grid, which is that time is tissue.
Time is tissue.
Right. When you look at an ECG strip, the horizontal axis isn't just distance. It is a strict measurement of time. One small square equals exactly 0.04 seconds. One large square is 0.20 seconds.
Okay.
If a signal takes too long to get from the breaker panel to the wiring in the walls, the tissue starves.
So we are hunting for delays, blockages, and rogue surges of electricity. Let's start with the most common clinical headache that absolutely fills up ICU beds across the world. The atrial chaos.
Atrial fibrillation and atrial flutter.
Exactly. Let's get the 80/20 overview on this.
So this is a massive drain on healthcare resources and a major cause of morbidity. The 80/20 overview here is that atrial fibrillation, or AFib, is total electrical disorganization in the top chambers of the heart.
The atria.
Right. You have multiple ectopic foci. These are basically rogue electrical cells firing rapidly and completely out of sync.
And how is flutter different?
Atrial flutter is similar, but instead of total chaos, it's usually a single rogue focus firing in a rapid macro reentrant circuit. It causes a very distinct sawtooth pattern on the monitor.
Okay, let's get into the pathophysiology. How do we get from a normal, organized heartbeat to a state where rogue cells are just firing off like fireworks? What's the actual trigger?
It almost always starts with structural stretch or ischemic damage. Think about a patient with chronic hypertension or heart failure or valvular disease.
The plumbing problems.
Exactly. The physical tissue of the atria gets stretched out over years or gets scarred from sheer physical stress. This structural change actually alters the ion channels at the cellular level.
Wait, so stretching the muscle physically changes its electrical properties?
Yes. The resting membrane potential of these atrial cells changes, making them incredibly irritable. They stop waiting for the main breaker panel, the SA node, to tell them what to do. They just start firing on their own.
So the physiologic change is that instead of a coordinated, smooth squeeze, the atria are just quivering, like a bag of worms.
It's exactly like a bag of worms.
Yeah.
The electrical impulses are firing at something like 350 to 600 times a minute in AFib.
Wow. And a quiver is definitely not a squeeze. It's terribly inefficient. But the body has a defense mechanism, right?
It does. The AV nodar relay box between the top and bottom of the heart acts like a bouncer at a nightclub.
Okay, bouncer.
Yeah, it has an inherent refractory period, meaning it simply cannot process 600 signals a minute. It physically blocks most of that chaotic electricity from reaching the ventricles.
But the bouncer can only do so much. Eventually, the AV node gets overwhelmed and too many signals slip through.
Right, and when too many signals slip through, the ventricular rate, the actual main pumping chambers, jumps to over 100 beats per minute, sometimes up to 150 or 170.
And that leads to decompensation.
Immediate decompensation.
Yeah.
Because the atria are just quivering, you lose what we call the atrial kick.
The atrial kick, that's the final active squeeze of blood from the atria into the ventricles right before the ventricles contract, right?
Yes.
How much of our total cardiac output relies on that little kick?
It's massive. In a healthy person, the atrial kick provides about 20 to 30% of ventricular filling the preload.
Oh, wow.
So if you lose the atrial kick because the atria is just vibrating, you instantly lose 20 to 30% of your cardiac output.
Just gone.
Just gone. The clinical findings that result are immediate. The patient feels dizzy, their blood pressure drops, they might feel palpitations or shortness of breath.
So if I'm at the bedside assessing this patient, what am I looking for early on, and what is the dangerous finding that requires immediate action?
Early on, they might just complain of fatigue or palpitations.
Yeah.
But the classic assessment finding, the one you will physically feel when you check their radial pulse, is a rhythm that is irregularly irregular.
Irregularly irregular, meaning there's no pattern at all.
There is no pattern whatsoever. It's completely chaotic because the AV node is just letting those signals through at random intervals.
Got it. And the dangerous phase?
The dangerous phase is what we call rapid ventricular response, or RVR. This is when the bouncer at the AV node completely fails and the ventricles start beating at, say, 160 times a minute.
Which doesn't leave enough time for the heart to fill up with blood.
Exactly. At that speed, the heart simply does not have time to fill with blood during diastole. If the plump is empty, it doesn't matter how fast it's beating. Cardiac output plummets.
So you'd see profound hypotension.
Hypotension, cold and clammy skin, as peripheral perfusion drops, and a decreased level of consciousness because the brain is starving for oxygen.
Well, let's talk diagnostics. Obviously, the ECG is our primary tool here. What does this chaos look like on the grid?
On the ECG, AFib shows a chaotic, squiggly baseline. There are absolutely no measurable P waves because there is no uniform atrial depolarization.
Just noise.
Just noise. But the QRS complex, the ventricular beat, is usually perfectly narrow and normal. It's just completely irregular in its timing.
And for flutter?
For atrial flutter, the bouncer at the AV node is a bit more organized. You'll see very distinct F waves, a sawtooth pattern, often in a mathematical ratio like 2 to 1 or 3 to 1, with the QRS complexes.
Yeah.
But in both cases, your PR interval is completely unmeasurable.
Okay, so let's run the ADPIU on this. I'm an ICU nurse. I walk into the room, and the monitor is showing this irregular chaos. The patient's heart rate is 140. What is my immediate priority? Like, what am I doing first, next to, and then?
Your absolute first priority is assessing the patient's hemodynamic stability. Treat the patient, not the monitor. Are they maintaining their blood pressure? Are they alert and oriented? Or are they pale, diaphoretic, and hypotensive?
So the highest priority nursing diagnoses here would be risk for decreased cardiac output and risk for impaired tissue perfusion.
Spot on.
Let's say their blood pressure is okay for now, but the heart rate is still 140. What's the intervention? Next T, and then.
Our measurable goal for planning is to drop that heart rate below 100 beats per minute. We do this primarily through rate-controlling medications. The big guns here are calcium channel blockers, specifically diltiazem, or beta blockers like metoprolol.
I really want to dig into the pharmacology here. Why those specific drugs? How do they actually work to fix this?
They target the AV node. Remember, the AV node is the bouncer. Diltiazem blocks the influx of calcium ions into the pacemaker cells of the AV node during phase 0 of the action potential.
Okay.
This literally slows down the electrical conduction through the node. It makes the bouncer stronger and slower.
Makes sense. And metoprolol.
Metoprolol does something similar, but through beta-1 adrenergic blockade, blunting the sympathetic nervous system's effect on the heart. By slowing the conduction through the AV node, fewer chaotic signals reach the ventricles, the heart rate drops, filling time increases, and cardiac output improves.
What about amiodarone? Because I see that used a lot in the ICU.
Amiodarone is a potent class 3 antiarrhythmic. Instead of just slowing the heart rate, it actually attempts to convert the chaotic rhythm back to a normal sinus rhythm.
Oh, so it's a rhythm controller, not just rate.
Right. It works primarily by blocking potassium channels, which prolongs the repolarization phase, the reset period of the cardiac action potential. It forces the chaotic cells to take a longer pause, hoping the SA node will step back in and take over.
Okay, so we're giving diltiazem to slow the rate. But the other major medication class we have to talk about with AFib is anticoagulants. Things like heparin drips in the acute phase or apixaban and warfarin long-term.
Very important.
But wait, I'm looking at this critically. If the primary problem is an electrical failure, why are we giving medication that alters the hematological system? Like, why are we thinning the blood?
That is the most important critical thinking question you can ask, and it's a massive safety concept. Because the atria are quivering and not actively squeezing, the blood inside them becomes stagnant.
Oh, right.
It just pools in the corners, specifically in a small pouch called the left atrial appendage.
And stagnant blood coagulates.
Exactly. Virchow's triad tells us that stasis of blood flow leads to thrombosis. A clot forms in that appendage. Now, imagine we give amiodarone or we use electricity to shock the heart back into a normal rhythm.
The atria suddenly snap back into a strong, forceful contraction.
Yep.
And it's going to squeeze that clot right out of the appendage.
Right out of the left atrium, into the left ventricle, up the aorta, up the carotid arteries, and straight into the brain. You will cause a massive ischemic stroke.
That is terrifying. The electrical problem creates a mechanical flow problem, which creates a hematological clotting problem, which ultimately results in a catastrophic neurological problem. It really proves why you can't just look at the heart in isolation.
Which is exactly why, if a patient has been in AFib for longer than 48 hours, or honestly, if we don't know exactly when it started, we absolutely cannot cardiovert them.
Right.
We cannot shock them back into a normal rhythm unless we aggressively anticoagulate them first, or we perform a procedure called a transesophageal echocardiogram, a T.
Let's explain the T procedure. Why not just do a regular ultrasound on their chest?
A standard transthoracic echocardiogram on the outside of the chest can't see the left atrial appendage clearly because the lungs and ribs get in the way. So we sedate the patient, pass an ultrasound probe down their esophagus, and look directly at the back of the heart.
Oh, that makes sense.
Yeah, if we see a clot in that appendage, cardioversion is strictly contraindicated.
So, checking for deterioration. I know my patient's getting worse if their heart rate climbs above 150, their blood pressure plummets, or they suddenly complain of chest pain.
Yes. Chest pain means the rapid heart rate has outstripped the oxygen supply to the coronary arteries themselves. The myocardium is becoming ischemic. You would escalate this immediately.
Okay, so notifying the provider versus calling a rapid response.
If they are stable but the rate is creeping up, you notify the provider. If they become hypotensive or develop chest pain, you call a rapid response or initiate your emergency protocols.
Let's touch on differentials. How do I distinguish AFib from other tachycardias on the monitor, like, say, PSVT?
Pattern recognition. If you see a sudden, regular, fast rhythm, say exactly 160 beats per minute, perfectly marching out, think ESVT, paroxysmal supraventricular tachycardia, the key word is regular.
Regular. Got it.
But if it's chaotic, fast, and the QRS complexes are completely unevenly spaced, it's AFib.
Let's summarize the atrial chaos using intensivist thinking.
Okay. Problem. A fast, irregular heart rate originating in the atria, failing physiology, loss of ventricular filling time, and the loss of the atrial kick leading to stagnant blood.
Right.
Immediate threat. Cardiogenic shock from poor output or an ischemic stroke from a rogue clot. Intervention. Rate control with calcium channel or beta blockers and aggressive anticoagulation. And reassessment. Monitor for a heart rate under 100, stable blood pressure, and intact neurological status.
So if I'm distilling this down for my shift tonight, if I remember only 5 things. The core pathophysiology is the loss of the atrial kick. The key assessment finding is that irregular pulse. The most dangerous complication is a stroke. My priority action is assessing hemodynamic stability before I ever look at the monitor, and the definitive treatment involves rate control and anticoagulation.
Perfect. The clinical picture in one sentence. An older adult with underlying heart disease presents with an irregular heartbeat, dizziness, and a dropping blood pressure. If you see a chaotic baseline with no P waves, think atrial fibrillation and immediately assess their hemodynamics while preparing rate control medications.
Okay, let's shift our focus down the conduction pathway. We just talked about the AV node acting as the bouncer, protecting the ventricles from the chaos in the atria. But what happens when the AV node goes on strike? What happens when the wiring connecting the upstairs to the downstairs is completely severed?
We're talking about high-grade AV blocks.
Yes.
This is where things get lethal very quickly. The 80-20 overview here focuses exclusively on the highly dangerous blocks. Second degree, type 2, also known as Mobitz 2, and third degree, which is complaint heart block.
Okay.
This is a scenario where the electrical signal from the SA node completely fails to reach the ventricles. It destroys tissue perfusion and absolutely requires external pacing to save the patient's life.
Walk me through this cellular and structural pathophysiology. What actually triggers the AV node or the bundle of His to just stop conducting?
The most common trigger is acute ischemia, specifically a myocardial infarction involving the right coronary artery, the RCA.
Oh, interesting.
Yeah, the RCA supplies blood directly to the AV node in about 90% of the population. If that artery gets blocked, the AV node literally suffocates and stops conducting electricity.
What else causes it?
Other triggers include severe calcification of the conduction system in older adults, or drug toxicity, particularly from digoxin, or an overdose of beta blockers.
So the physiologic change is that the pathway is blocked. In type 2, it's intermittently blocked. In third degree, it's completely severed. How does the body compensate for a completely severed electrical connection?
The body has a desperate backup plan. The cells in the ventricles, the Purkinje fibers, have their own intrinsic automaticity. They realize that no signal is coming from above, so they try to fire on their own to keep the pump working. This is called a ventricular escape rhythm.
But the wiring in the walls isn't designed to be the main breaker panel.
Exactly. The phase 4 spontaneous depolarization of a Purkinje shell is incredibly slow. An escape rhythm from the ventricles will only generate a heart rate of 20 to 40 beats per minute.
Beating 20 times a minute, I mean, that's catastrophic.
Decompensation is immediate. Cardiac output is a simple mathematical equation. Heart rate multiplied by stroke volume. If your heart rate drops from 80 to 25 instantly, your cardiac output completely collapses.
So you'd see instant shock.
The clinical findings reflect this sudden loss of perfusion. The patient experiences immediate syncope, crushing chest pain because the heart itself isn't getting blood, and profound cardiogenic shock.
If I'm assessing this patient, what am I looking for? Early versus late?
Early on, they might just complain of profound sudden fatigue or dizziness, but the classic finding is a heart rate in the 30s.
And the late dangerous findings?
Complete syncope, cold and mottled skin, absent peripheral pulses, and eventually periods of apnea as the respiratory center in the brain shuts down from lack of blood flow.
Let's look at the diagnostics. How do we differentiate these lethal blocks on the ECG grid?
For second-degree type 2, you will see a normal constant PR interval on the beats that do conduct. The signal makes it through. But then suddenly and unpredictably, there is a dropped QRS complex. You see a P wave, and then absolutely nothing. The signal was blocked.
And for third degree?
For a third degree or complete heart block, it is a total divorce between the atria and the ventricles. The SA node is firing normally, so you see P waves marching out regularly at, say, 80 beats per minute.
Okay.
But the ventricles are firing on their slow escape rhythm at 30 beats per minute. The keyways and the QRS complexes have absolutely no relationship to each other. They're beating completely independently.
So if I recognize this on the monitor and I see my patient is hypotensive and altered ADPIE time, what is my immediate priority?
Your diagnosis is inadequate tissue perfusion related to extreme bradycardia. Your goal is to restore the heart rate to greater than 60 beats per minute immediately.
Let's talk medications for a second, because this seems straightforward. If the heart is beating at 30 beats a minute, I'm reaching for 5E atropine, right? We use atropine to speed up symptomatic bradycardia. I'll just push a milligram of atropine and speed the heart back up.
I am so glad you brought that up because this is a massive exam trap and a potentially fatal real-world error.
Oh, wow. Okay.
You must understand the pharmacology of atropine to understand why it is completely useless in a complete heart block.
Okay, let's unpack that. How does atropine actually work?
Atropine is an anticholinergic drug. It works by blocking the parasympathetic vagus nerve, which normally acts like a brake on the SA and AV nodes. By removing the brake, atropine allows the AV node to fire faster.
Ah, I see the problem.
Right. In a third-degree block or a type 2 block occurring below the AV node in the bundle of His, the tissue is dead or physically severed. The bridge is out.
So atropine just doesn't do anything.
You can give all the atropine you want to stimulate the top of the bridge, but the signal still cannot cross the gap. Shouting at a severed wire won't make the electricity jump across. You don't need a chemical stimulant. You need raw, external electricity.
That makes perfect sense when you understand the mechanism. So if atropine is out, what is the implementation? First, next, then?
First, check responsiveness and blood pressure. Next T, apply the transcutaneous pacemaker pads, the TCP pads, immediately. Then, you might start an infusion of epinephrine or dopamine to provide some chemical inotropic support and clamp down the blood vessels while you wait for a temporary transvenous pacer insertion.
Let's walk through the physics and the procedure of transcutaneous pacing. We're literally shocking the heart through the skin, right?
Yes, we are. You place one large pacing pad on the anterior chest, roughly over the V4 lead position, and the other pad on the posterior back, right between the spine and the left scapula.
Okay.
You turn the machine to the pacing mode, set your desired rate, usually around 70 beats per minute, and then you slowly increase the electrical current, measured in milliamps.
You're trying to force the electrical current through the chest wall, through the lungs, and into the ventricular muscle to force it to depolarize.
Exactly. You increase the milliamps until you achieve what we call capture. Electrical capture means that on the monitor, every single pacing spike is immediately followed by a wide QRS complex. The electricity has successfully depolarized the ventricles.
But remember, the monitor can lie.
Yes, you must also confirm mechanical capture.
Meaning you have to feel a physical pulse that matches the pacing rate.
Yes. If the machine says it's pacing at 70, but you only feel a weak pulse of 30, you do not have mechanical capture. You need to increase the current or reposition the pads.
What are the complications of doing this? It sounds brutal.
It is incredibly brutal. Think about it. You are blasting electrical current through the skeletal muscles of the chest wall to reach the heart. The patient's chest will visibly jump and twitch with every single heartbeat. It is agonizingly painful.
So we need to sedate them.
A major novice mistake is failing to advocate for the patient's pain. If the patient is conscious and their blood pressure can tolerate it, you must sedate them and provide heavy analgesia. You are torturing them to save their life, but you should minimize the torture.
How do I know if the situation is escalating out of my control? The deterioration phase.
The patient is deteriorating if they lose consciousness, if the pacing fails to capture despite maximum milliamps, or if they slip from profound bradycardia into complete ventricular standstill asystole. If they lose their pulse entirely, you immediately escalate from pacing to full CPR and a code blue.
Let's do differentials. I know we discussed this briefly, but how do I quickly tell a type I block from a type 2 block? Because they both drop beats, right?
Pattern recognition is key here. Type I, also known as Wenke block, is a progressive fatigue of the AV node. You will see the PR interval getting longer and longer and longer on successive beats, and then finally a dropped QRS.
So it gives you a warning.
Exactly. It's predictable. It's usually benign, and we just watch and wait. But if you see constant identical PR intervals and then a sudden unpredictable dropped beat without any warning, think type 2 and prepare to pace them. That patient is teetering on the edge of complete heart block.
Let's run the intensivist thinking for high-grade AV blocks.
Right. Problem: a physically severed or ischemic electrical connection between the top and bottom of the heart. Failing physiology. The ventricles are relying on an escape rhythm of 20 to 30 beats per minute, immediate threat, profound cardiogenic shock, and biological death.
Right.
Intervention. Transcutaneous pacing to force the ventricles to beat, bypassing the broken wiring. Reassessment. Confirm electrical capture on the monitor and mechanical capture by checking a pulse and blood pressure.
If I'm boiling this down to my 5 things, the core patho is a complete disconnect between the atria and the ventricles. The key assessment finding is profound bradycardia with syncope. The most dangerous complication is cardiogenic shock. My priority action is applying the TCP pads immediately. And ultimately, this patient will need a permanent, surgically implanted pacemaker.
That's it, the one-sentence clinical picture. A patient having an active right-sided myocardial infarction suddenly drops their heart rate to 30, loses consciousness, and shows absolutely no correlation between P waves and QRS complexes on the monitor.
So if you see P waves marching completely independently of QRS complexes, think third-degree heart block and immediately apply a transcutaneous pacemaker. Do not waste time with atropine.
Perfectly said.
Okay, we've covered the heart beating too slowly. Now we need to discuss the absolute nightmare scenario in the ICU, the code blue killers.
The scariest part of the job.
This is when the main breaker panel shorts out and the downstream wiring just takes over at warp speed. Ventricular tachycardia and ventricular fibrillation.
This is where every single second counts. Irreversible brain damage begins in minutes. The 80-20 overview. Ventricular tachycardia, or VT, is defined as 3 or more premature ventricular contractions PVCs in a row, usually firing at a terrifying rate of 150 to 250 beats per minute.
And ventricular fibrillation.
Ventricular fibrillation, or VF, is even worse. It is a completely chaotic, disorganized quivering of the entire ventricular muscle mass. Both of these are universally lethal without rapid intervention, and both require immediate advanced cardiovascular life support, or ACLS.
Let's dive deep into the cellular pathophysiology. What actually triggers the ventricles to go rogue like this?
The triggers are usually profound physiological insults. Severe ischemia, like a massive left anterior descending artery occlusion, starves the ventricular cells of oxygen, causing their resting membrane potential to destabilize. Critical electrolyte imbalances are also massive triggers.
Specifically hypokalemia or hypomagnesemia, right? Low potassium and low magnesium.
Yes.
Let's explain why. Why does low potassium make the heart more irritable? I think a lot of people just memorize that fact without understanding the actual mechanism.
It has to do with the repolarization phase of the cardiac action potential. Potassium is responsible for flowing out of the cell to restore the negative electrical charge after a heartbeat.
So the reset.
Exactly. If your serum potassium is low, this efflux is delayed. The repolarization phase is prolonged. This leaves the cardiac cells in a vulnerable, hyperexcitable state for a longer period.
And that leads directly to the R on T phenomenon, doesn't it?
Exactly. The R on T phenomenon is the classic trigger for lethal dysrhythmias. The T wave represents ventricular repolarization. The peak and downslope of the T wave is the relative refractory period. The cells are resetting, and they are incredibly unstable.
So if a random impulse hits them then?
If a random rogue electrical impulse, a PVC, happens to fire and land exactly on that vulnerable T wave, it shatters the electrical grid. It sends the ventricles into a rapid chaotic tailspin of ventricular tachycardia or fibrillation.
Is there any physiological compensation for this, like, at all?
Absolutely none. The decompensation is instantaneous. Think about the physical mechanics of the pump. Because the ventricles are beating 250 times a minute in VT or just violently vibrating in VF, diastole essentially ceases to exist.
There's no relaxation phase.
Right. If the ventricles never relax, they never fill with blood. If there's no blood in the chamber, there is no blood to pump out to the body. Cardiac output drops to absolute zero immediately.
So the clinical findings are exactly what you'd expect when blood flow to the brain and body stops.
Yes. The patient is completely unresponsive, pulseless, apneic, and clinically dead.
Let's talk assessment. Are there any early warning signs before this happens, or is it just bam, they're dead?
Early on, you might see warning signs on the monitor. Frequent PVCs or runs of 2 or 3 PVCs together, but often it is sudden. The classic finding on the monitor for VT is wide, distorted QRS complexes. For VF, it's just chaotic, wavy, meaningless lines.
And the dangerous finding is the loss of a pulse. But I want to clarify something. Can a patient in ventricular tachycardia still have a pulse?
This is a critical distinction. Yes, for a very brief period, a patient in VT might have a pulse and be conscious if their heart is still managing to squeeze out a tiny fraction of blood. We call that stable VT.
Okay.
But it will rapidly deteriorate into pulseless VT. Ventricular fibrillation, however, never has a pulse. VF is always clinical death.
Diagnostics. We obviously aren't waiting for a 12-lead ECG or lab results to confirm this.
No. You read the rhythm on the monitor in front of you. VT looks like a continuous rapid row of wide, bizarre QRS complexes greater than 0.12 seconds wide. They often look perfectly identical to each other, which we call monomorphic VT. The T wave is usually deflected in the opposite direction of the QRS.
And VFib?
VF shows no measurable waves whatsoever. It looks like electrical static.
Okay, I walk into the room. The monitor shows VFib. 80 PIE time. What are my priority nursing actions? First, next, then.
First, you check the patient, not the monitor. Do they respond? Do they have a carotid pulse? You must verify pulselessness. Next T. If there is no pulse, you initiate high-quality CPR immediately and call for help. Hit the code blue button.
Right, and then?
Then, you must defibrillate the patient as rapidly as possible, ideally within 2 minutes of the arrest.
Let's talk about the physics of defibrillation versus cardioversion. We discussed synchronized cardioversion earlier for AFib, but here we are using defibrillation. What is the difference?
Defibrillation is a massive, unsynchronized blast of raw electricity. We usually use a biphasic defibrillator, delivering between 120 and 200 joules of energy. The electricity travels from one pad to the other, completely depolarizing every single cell in the myocardium simultaneously.
You're trying to flatline them, basically.
Exactly. That's a great way to think about it. You are causing a momentary total electrical standstill. The goal is to shut down all the chaotic rogue cells at once, with the hope that the main breaker panel, the SA node, will wake up, realize it's quiet, and take back control of the grid.
So in defibrillation, the sync button is absolutely off.
Exactly.
Because if you used cardioversion.
If you use synchronized cardioversion, the machine looks for a QRS complex to time the shock. In VFib, there are no QRS complexes. The machine will just sit there, waiting forever, and it will never deliver the shock while your patient dies. Never use synchronized cardioversion on a pulseless patient.
During the code, what medications are we pushing?
Epinephrine is our primary drug.
Right.
We push 1 milligram every 3 to 5 minutes. Epinephrine is a potent alpha-1 adrenergic agonist. It causes profound peripheral vasoconstriction.
Okay, wait, why do we want vasoconstriction during cardiac arrest?
Great question. By clamping down all the blood vessels in the arms and legs, it forces whatever blood we are generating with CPR directly to the brain and the coronary arteries. We're maximizing central perfusion.
That makes sense. What about antiarrhythmics to fix the chaotic tissue?
We use amiodarone or sometimes lidocaine. Amiodarone prolongs the action potential, trying to stabilize that hyperexcitable ventricular tissue.
And magnesium. You mentioned low magnesium earlier.
Yes, if the patient is in a specific type of VT called torsades de pointe, where the wide complexes twist up and down like a party ribbon, the definitive drug is IV magnesium sulfate. Torsades is specifically caused by a prolonged QT interval, and magnesium stabilizes the cellular membrane and shortens that repolarization phase.
Complications here are obvious. If we don't fix it, they stay dead.
The major complication is anoxic brain injury. Every minute without CPR and defibrillation decreases the chance of survival by 7 to 10%. Your nursing action is to ensure high-quality CPR, push hard, push fast, and minimize interruptions to chest compressions to preserve that neurological function.
What are the biggest novice mistakes or exam traps when dealing with VT and VF?
2 major traps. First, the ultimate novice error, treating the monitor instead of the patient. Artifact from the patient brushing their teeth or a loose lead wire jiggling around can look exactly like coarse VFib on the screen.
Oh, man.
If you call the code and try to shock a patient who is sitting up talking to you, it's a disaster. Always check the patient's pulse first.
And the second trap?
If the patient has a permanent pacemaker or ICD implanted under their skin, never place the defibrillator pads directly over the device. The metal generator will absorb the shock, destroying the device and preventing the electricity from reaching the heart. Place the pad at least an inch away or use an anterior-posterior pad placement.
Let's do intensivist thinking for the code blue killers.
Problem: lethal ventricular chaos, failing physiology. No blood is pumping, diastole is eliminated, and the brain is actively dying. Immediate threat: irreversible biological death.
Got it.
Intervention: you become the mechanical pump by providing high-quality CPR, and you reset the electrical grid with rapid defibrillation. Reassessment, pulse check, and rhythm check every 2 minutes.
Okay, so locking in the 5 core things to remember. The patho is the ventricles quivering or beating too fast to fill, dropping output to 0. The assessment is pulselessness and apnea. The complication is biological death. The priority action is starting CPR immediately. And the definitive treatment is rapid, unsynchronized defibrillation.
The clinical picture. A patient with severe hypokalemia suddenly loses consciousness, loses their pulse, and shows wide, continuous, bizarre waveforms on the monitor.
So if you see chaotic, irregular waveforms with no discernible QRS, think ventricular fibrillation and immediately start CPR and defibrillate.
Absolutely.
Okay, that brings us to the next scenario, which I think is conceptually the trickiest one for a lot of people to grasp. What if the monitor shows a rhythm, maybe even a perfectly normal, beautiful sinus rhythm, but the patient looks completely dead? Or what if there's just a flat line? We need to talk about PEA, pulseless electrical activity, and asystole.
This scenario is the ultimate deception in the ICU. The 80-20 overview here is that PEA is the presence of organized electrical activity on the monitor, but the heart muscle is failing to respond mechanically. There is no pulse.
And asystole?
Asystole is the total, catastrophic absence of both electrical and mechanical activity. It is a flat line. The absolute most crucial fact you must internalize is this. Electricity, meaning a shock from a defibrillator, will not fix either of these. They are non-shockable rhythms.
Let's really dig into the pathophysiology of PEA, because how is it physically possible that the electrical grid is working perfectly, but the pump isn't pumping?
Let's go back to our house metaphor. The main breaker panel is working. The wires in the walls are transmitting the electrical current perfectly. But down in the basement, the physical water pump is completely dry, or it has been crushed by a fallen beam.
The electricity is telling the pump to turn on, but it mechanically cannot move water.
Exactly.
So what causes the pump to fail if the electricity is fine?
We categorize the triggers as the H's and T's. Hypovolemia is a classic example. Massive blood loss. If a trauma patient bleeds out, their heart is completely empty. The SA node is frantically sending out electrical signals, which look like a normal sinus rhythm on a monitor, but there is no physical blood to pump. The cardiac output is zero because the preload is zero.
Wow, what about the T's?
A great example is cardiac tamponade. This is when fluid or blood rapidly fills the pericardial sac surrounding the heart. The fluid exerts massive physical pressure on the myocardium, physically crushing the ventricles so they cannot expand during diastole.
Oh, so again, the electrical signal fires normally, but the muscle is physically trapped and cannot squeeze.
Exactly. Other causes include profound hypoxia, severe acidosis, or tension pneumothorax.
So the physiologic change is that the muscle is either deprived of volume, deprived of oxygen, or physically compressed, rendering it incapable of responding to the electrical command.
Exactly. The decompensation is identical to VFib, total cardiovascular collapse. The clinical findings are an unresponsive, pulseless, and apneic patient.
Assessment is straightforward. Classic and dangerous findings are no pulse, no breathing. What about diagnostics? How does this actually look on the grid?
Asystole is a flat line, just a slight wandering baseline with zero electrical complexes. PEA, however, can look like absolutely any organized rhythm on the monitor. It can look like sinus bradycardia, a junctional rhythm, or even a perfect normal sinus rhythm at 80 beats per minute.
Which is wild.
That is why you can never trust the monitor in isolation. You must check the patient.
Priority nursing actions. I walk in, see a normal rhythm, but my patient is blue and pulseless. First, next T, then.
First, you verify pulselessness. If the monitor shows a systole, you must verify that flat line in at least 2 different ECG leads to ensure it's not just a disconnected wire. Next T, you initiate high-quality CPR immediately. You have to be on the mechanical pump because theirs has failed.
And then?
Then you push epinephrine and you start acting like an intensive care detective to find and revert the underlying cause.
Let's talk medications. We push epinephrine, but no amiodarone, right? Why?
Correct. Just epinephrine. Remember the pharmacology?
Yeah.
Amiodarone is designed to stabilize highly irritable, chaotic electrical tissue in VT or VF. In PEA and asystole, the tissue isn't irritable. It's dead, dying, or empty. There's no electrical chaos to fix. We use epinephrine purely for its massive vasoconstrictive alpha-1 effects. We are trying to aggressively clamp down the peripheral arteries to increase the aortic diastolic pressure, which forces blood flow into the coronary arteries to feed the dying heart muscle.
But epinephrine alone isn't going to fix PEA, is it?
No, absolutely not. Epinephrine just buys you time. This is where hemodynamics and fluids come in. If the PEA is caused by hypovolemia from a massive hemorrhage, you can do perfect CPR and push epinephrine all day long, and the patient will still die.
You have to fix the plumbing.
Exactly. The definitive treatment is to rapidly infuse massive blood transfusions and IV fluids to refill the pump. If the cause is a tension pneumothorax, the provider must perform an immediate needle decompression to release the trapped air. You have to fix the H or the T.
What's the biggest exam trap or clinical error here?
I cannot emphasize this enough. The ultimate error is shocking asystole or PEA. Hollywood gets this wrong constantly. You see a dramatic medical scene on TV, the monitor goes flat, the doctor yells clear, and they shock the flat line.
Right, you see that all the time.
That is medical illiteracy.
Because shocking only fixes electrical chaos.
Exactly. Defibrillation is designed to stop a chaotic rhythm so the SA node can reset. In asystole, there is no rhythm to stop. The grid is already dead.
So shocking it.
If you shock a dead heart, you are just firing high-energy electrical burns into dead tissue, causing further myocardial damage and completely eliminating any microscopic chance of recovery. Never shock a flatline.
That makes total sense. Intensivist thinking for the flatlines.
Problem: a dead or empty mechanical pump. Failing physiology. There is no mechanical response to the electrical grid, leading to zero cardiac output. Immediate threat. Irreversible brain death.
And intervention.
Intervention. You become the pump via CPR, you push epinephrine to preserve coronary perfusion, and you desperately search for the underlying H's and T's. Reassessment. Frequent pulse checks and lab results to guide your detective work.
So the 5 core things to remember. The patho is that the electrical system might work, but the mechanical pump has failed due to a systemic insult. The assessment is no pulse despite an organized rhythm on the screen. The complication is death. Priority action is CPR and epinephrine. And the absolute most important treatment is finding and reversing the underlying cause.
Perfect. The clinical picture. A trauma patient with massive internal bleeding shows a perfect normal sinus rhythm on the monitor, but has absolutely no palpable pulse.
So if you see an organized rhythm but the patient is pulseless, think PEA. Immediately start CPR and push epinephrine. Do not shock.
Exactly. Do not shock.
That brings us to our final scenario. We spent this entire time talking about the heart's natural electrical grid failing. But to wrap this up, let's talk about what happens when the very hardware we implant to save these patients starts failing on the job. Let's discuss pacemaker and ICD malfunctions.
This requires critical bedside troubleshooting. The 80-20 overview. Pacemakers are devices designed to pace a slow heart-treating things like our third-degree AV blocks. ICDs, or implantable cardioverter defibrillators, are designed to monitor for and automatically shock lethal rhythms like VT or VF.
Both rely on synthetic wires and batteries.
And both can fail. The big 3 malfunctions you must memorize are failure to sense, failure to capture, and failure to pace.
What triggers these million-dollar devices to fail? What's the pathophysiology of hardware failure?
The trigger is usually mechanical. The battery inside a generator depletes over time. Or the lead wire, the synthetic wire running from the device down into the right ventricle, gets physically dislodged from the heart wall.
Okay, what else?
Another major physiological cause is fibrosis. Over time, the body attacks the foreign metal wire and forms dense scar tissue right at the tip where it touches the myocardium. This scar tissue acts as an insulator, drastically increasing the electrical impedance.
So the electrical current from the pacemaker can't punch through the scar tissue to reach the muscle cells.
Precisely. Let's break down the 3 failures. In failure to sense, the device becomes blind. It is supposed to monitor the patient's intrinsic millivolts, but it fails to see the patient's own natural heartbeat, so it just fires its electrical spikes randomly.
Okay, blind. What's failure to capture?
In failure to capture, the device is weak. It fires precisely when it's supposed to, but the current, the milliamps, isn't strong enough to penetrate that scar tissue, so the muscle never contracts.
And failure to pace?
In failure to pace, the device is completely dead. The heart rate drops, but the device never sends a signal at all.
So if the device fails, the patient just reverts back to their original lethal dysrhythmia. They experience profound bradycardia, syncope, or worse. How do we assess this on the monitor? We're looking at the pacer spikes, right?
Yes. A pacer spike is a sharp, distinct vertical line on the ECG. In failure to capture the weak device, you will see a bright pacer spike, but it is followed by absolutely nothing, a flat line. No QRS complex follows the spike.
Okay, weak device, no QRS. What about the blind one?
In failure to sense, you will see pacer spikes landing randomly all over the ECG, completely out of sync, sometimes landing right on top of the patient's own natural QRS complexes.
And the dead one, failure to pace.
The patient's heart rate drops below the set limit, say down to 40, but there are absolutely no pacer spikes visible to try to help.
So if I'm managing a patient with a temporary transvenous pacemaker in the ICU, and I see failure to capture on the monitor, what are my priority nursing actions?
First, you check the physical connections. Trace the wire from the patient's neck down to the external generator box. Make sure the battery is good and the pins are locked in. Loose wires happen constantly.
Next T?
Next T. You adjust the settings based on the failure. If it's failure to capture, meaning the signal is too weak, you turn up the milliamps dial to give the device more electrical juice to punch through the resistance.
And if it's blind?
If it's failure to sense, you adjust the sensitivity dial, measured in millivolts, so the machine can see the heart better.
What if turning the dials doesn't work?
Then you use a fantastic physical nursing trick. Physically roll the patient onto their left side.
Wait, really? Just roll them?
Yeah. Gravity will pull the heavy ventricular muscle and the free-floating transvenous wire together, promoting better physical contact between the metal tip and the endocardium.
That is such a cool trick. What's the most dangerous complication of these failures?
The most lethal complication stems from failure to sense. Remember the R-on-T phenomenon we discussed with ventricular fibrillation?
Where a random spark hits the vulnerable T wave and shatters the grid.
Exactly. If the pacemaker is blind, it might randomly fire a high-energy pacing spike that lands exactly on the vulnerable T wave of the patient's natural beat.
Oh, no.
The pacemaker itself triggers the R-on-T phenomenon, throwing the patient directly into iatrogenic ventricular fibrillation. Your action is to immediately start CPR and defibrillate the patient you just accidentally coded.
That is the ultimate nightmare scenario. Let's talk about patient education for permanent pacemakers, because I know that is heavily tested and crucial for long-term survival.
Patient teaching is paramount. First, infection control. Keep the surgical incision perfectly dry for at least 4 days. Second, mechanical protection. The patient must not lift the arm on the side of the pacemaker above their shoulder for several weeks.
Why? What happened?
If they reach up to grab something off a high shelf, the muscle movement will literally rip the newly implanted fragile lead wire right out of the ventricular wall.
Yikes. Okay. What about environmental hazards like magnets, microwaves?
Microwaves are totally safe. That's an archaic myth from the 1970s. However, MRI machines are generally a hard contraindication.
Because of the magnets?
Right. The massive magnetic field of an MRI can literally heat the metal wires inside the heart, burn the tissue, or physically rip the generator out of the chest pocket. Unless the patient has a very specific modern MRI conditional device, they cannot go into that scanner.
Let's run the intensivist thinking for hardware failure.
Problem. The synthetic hardware is failing to read or stimulate the heart, failing physiology, a return of the patient's underlying lethal dysrhythmia, and a massive drop in cardiac output. Immediate threat, syncope or pacemaker-induced cardiac arrest.
And the intervention?
Intervention, troubleshoot the external device settings by adjusting milliamps or sensitivity, and support the patient's ABCs. Reassessment, continuous ECG monitoring to ensure every pacing spike is followed by a QRS complex.
So if I'm writing down the 5 key takeaways, the patho is that the device fails to monitor, fire, or stimulate the muscle due to battery, wire, or impedance issues. The assessment is a heart rate dropping below the set limit, leading to syncope. The complication is the R-on-T phenomenon, leading to VF if the device fails to sense. The priority action is to check connections and increase the milliamps if there is no capture. And the treatment is repositioning the patient and interrogating the device.
The clinical picture. A patient with a temporary transvenous pacemaker suddenly becomes dizzy, and the monitor shows sharp pacer spikes marching right through their intrinsic QRS complexes without generating any new heartbeats.
So if you see a pacer spike followed by a flat line instead of a QRS, think failure to capture and immediately increase the electrical milliamps on the generator.
Spot on.
Wow, we have been on a massive journey through the electrical grid of the heart today. We started by identifying the chaotic flickering lights and the stroke risks associated with atrial fibrillation.
We covered a lot.
We really did. We learned how to recognize the absolute severed wiring of a third-degree heart block, and we proved exactly why giving atropine in that scenario is a deadly pharmacological trap. We tackled the explosive power surges of ventricular tachycardia and fibrillation and broke down the vital physics of defibrillation versus cardioversion. We untangled the ultimate deception of PEA, where the monitor lies to you because the electrical panel is fine but the plumbing pump is dry. And finally, we troubleshot the physical failures of the smart home devices we implant to try and fix all of this.
It is an overwhelming amount of information if you try to just memorize it. But by aggressively applying that intensivist thinking, always tracing the problem down to the cellular physiology, identifying the immediate hemodynamic threat, implementing the targeted intervention, and reassessing it, stops being a list of facts and becomes a logical biological sequence.
Right.
But before we finish, I want to leave you with a final provocative thought regarding the horizon of critical cardiac care.
Oh, let's hear it.
We just spent that last entire segment discussing how broken synthetic leads, dislodged wires, and dead batteries cause pacemakers to fail. The wires are the weakest link. But what if we completely eliminated them?
Wait, like a wireless pacemaker?
Yes.
Yeah.
We are currently entering the era of leadless permanent pacemakers. These are entirely self-contained tiny capsules, about the size of a large vitamin pill.
No way.
Yeah, they are navigated up through the femoral vein and injected directly into the wall of the right ventricle. There are absolutely no wires attached and no generator pocket cut into the chest.
That eliminates the risk of dislodging a lead by raising your arm, and it eliminates the risk of pocket infections.
Exactly, but it gets even more fascinating. Researchers are currently developing experimental devices that don't even use chemical batteries.
Wait, how do they get power?
They utilize piezoelectric materials to harvest kinetic energy directly from the physical motion of the heartbeat itself. The physical squeezing of the heart generates the microvoltage needed to power the microprocessor.
So, going back to our metaphor, the house of the future won't have fragile wires buried in the walls, and it won't need a battery backup. The movement of the house itself will generate the electricity required to keep the grid online. The electrical grid will literally heal and power itself. That is incredible.
It completely changes everything we know about troubleshooting these devices. The future of intensivist care is always evolving.
Thank you all for joining us on this deep dive into the intensive care unit. Remember, whether you are managing a stable AFib patient or running a chaotic code blue, stay curious, constantly rely on your cellular pathophysiology, and always treat the patient, not just the monitor.